Hi there. Hi to all the attendees of the 2022 Law and Mental Health Conference. Thank you so much for having us. We're really excited to be here. My name is Jason Tanda Bibiana, and I'm a research institute with the Vera Institute of Justice and our Redefining Public Safety program.
And hi, my name is Jackson Beck. I'm a program associate with the Redefining Public Safety team, and my work focuses on qualitative research and policy advocacy at the intersection of policing and behavioral health.
Thanks, Jackson. So the Vera Institute is a national nonprofit organization that works to end criminalization and incarceration across the criminal, legal, and immigration systems through research, technical assistance, and advocacy. And Jackson and I are calling in today from Brooklyn, New York, which is the traditional territory of the Lenape and Canarsie peoples. For today's session, we're really excited to be sharing highlights from our ongoing work on race, equity, and behavioral health crisis alternatives. So the strategies, lessons learned, and promising practices that we'll be sharing today are based on interviews that our team completed with advocates, program leaders, and researchers with professional and lived experience in areas including behavioral health, crisis response, policing, 911 communications, and peer support. Most of our interviews and research took place throughout 2021, and we aim to learn from local programs and communities at different stages of planning and implementing crisis response programs. We also sought to include stakeholders with subject matter expertise in key areas relating to equity work, including racial equity, immigration, disability justice, peer advocacy, and workforce development. So in terms of the session outline for today, Jackson will start by highlighting the importance of prioritizing equity in the development, implementation, and evaluation of crisis response programs. We'll also share a framework for identifying decision-making points and opportunities to promote equity at each stage of the journey, from caller to crisis response. And then we'll highlight a few specific areas of program development and implementation, sharing strategies and ways that programs are taking steps to create more equitable approaches to support people in crisis. And what we're sharing today is a preview of a forthcoming report that will be published on Vera's website in the spring of 2022. Thanks again for the opportunity.
Great, thanks, Jason. So just to start things off, I'd like to help establish what we mean when we use the term racial equity. Race Forward defines racial equity as a process of eliminating racial disparities and improving outcomes for everyone. And the focus on process is important. They explain that it's the intentional and continual practice of changing policies, practices, systems, and structures by prioritizing measurable change in the lives of people of color. So why do we prioritize it? Black communities and other communities of color have disproportionately shouldered the harms of policing, including arrest, incarceration, and police violence. The tragic killings of Daniel Prude and Deborah Danner in New York, Walter Wallace Jr. in Philadelphia, Joseph Dwayne Robinson in Memphis, and far too many others experiencing behavioral health crises have driven community demands for systemic change, and change that acknowledges the harms of policing as well as their racially disparate impacts. Reducing police involvement in crisis response is an important step toward better serving people with unmet behavioral health needs who have faced criminalization rather than appropriate care. At the same time, by itself, making a civilian crisis response option available as an alternative to police will not eliminate inequities at the intersection of policing and behavioral health. Communities must prioritize racial equity as they plan, implement, and evaluate civilian crisis response programs to address the needs of those communities that are most harmed by status quo approaches. And finally, we chose to focus on racial equity specifically for this project because of how racial disparities in particular have characterized policing in the US since its inception. At the same time, we think it's critical to consider how policies, practices, systems, and structures have also created other inequities that hinder people's access to appropriate, timely care. And we'll be sharing some of those examples later in this presentation as well. So as we think about the meaning of racial equity in the context of crisis response, it's helpful to consider decision-making points in crisis situations that may produce inequities and might also offer opportunities to proactively address them. So starting with the caller, there's the decision of whether to call for help for oneself, friends, family, and in some cases, strangers. And the decision of who to call once someone has decided to make a call at all 911, a crisis line, or another number. And this can be influenced by trust in 911, awareness of and access to crisis services, and in cases involving strangers, ambiguous safety concerns or suspicions that may reflect racial bias in some cases. So there are a number of factors we might be thinking about there. At the 911 dispatch level, there's the decision potentially to divert a call to a crisis line. And this could be influenced by the availability of a crisis line to accept, that can accept a warm handoff from 911. There's the call taker ability to identify a behavioral health component in that call, criteria at that 911 call center for making the diversion, and both caller and call taker perceptions of safety and dangerousness in assessing that crisis situation. There's also the decision to direct a call in the case of an in-person response to a civilian response team, a co-response team, or a potentially CIT-trained police officer or officers. And you'll see at the bottom of the screen here, I've included a typology from Vera's November 2020 report on behavioral health crisis response alternatives. And this just illustrates that there's the spectrum of responses from police-based to community-based responses that are more civilian-led. For the purposes of this report that we developed, we really wanted to focus on this last approach as promoting equity, but there are a number of factors to think about here in what drives this dispatch decision. There's whether one of these alternative approaches is available to respond in the first place in a given neighborhood or jurisdiction. There's the call taker ability to identify a behavioral health component in that crisis situation. And then there's criteria for dispatching these various responses that might be available. And finally, there's the crisis response itself. So in this in-person response, you have multiple decisions, right? There's the decision whether to refer someone to voluntary services and transport them, or potentially involuntarily transport them to a hospital, emergency department, or a crisis facility. And these kinds of decisions will depend on the ability to connect and identify with someone in crisis in that moment on the part of the responders, on-scene protocols driving the program, and what the options are that they have as far as available places to go and bring someone who's experiencing a crisis. There's also the decision to call for police backup, and this could be influenced by on-scene response protocols and perceptions of safety and dangerousness. And of course, we need to think about decision-making points for police who arrive on a scene. So can they resolve a situation without the use of arrest, citation, or the use of force? And if there's still first responders, but they identify a behavioral health component in the situation, will they call in crisis workers, clinicians, or other responders that can support them in delivering an appropriate intervention? So those are a few considerations and decision-making points animating a crisis situation from caller to crisis response. And I'll turn it over to Jason now, who will talk a bit more about the 911 dispatching stage.
Thanks. So Jackson just noted how there's all these different stages in the crisis situation that have decision-making and opportunities to promote equity. So next, we want to share some strategies and examples of ways that we've been learning about how crisis response programs can put this into practice. And I'll cover these first few stages of someone calling for help and how 911 and crisis line call takers and dispatchers receive those calls and identify and dispatch appropriate response. So for increasing access for callers, two strategies that we've been learning about are maximizing the access points and different numbers to call, and addressing and overcoming communication barriers. In most communities, 911 is still the default number to call to receive the most timely response for an emergency, including for behavioral health crises. However, among communities of color and many other community members who've had negative experiences and harms from policing and 911, there may be hesitancy to actually call 911 in that moment of crisis. So while many crisis response programs are accessible through 911, many are also considering other numbers and other ways for community members to access and call them. In Eugene and Springfield, Oregon, the CAHOOTS program is accessible through 911, but they are also accessible through a 10-digit non-emergency line that connects back to the same communication center. For Portland Street Response in Portland, Oregon, the pilot program is currently only accessible through 911, but during its pilot, they encouraged community members to specifically request Portland Street Response when they were calling for a person in crisis. In Rochester, New York, the person in crisis team is accessible through 911 and through 211. And in Rochester, 211 is the region's 24/7 crisis line. And the person in crisis team is actually focused on publicizing and raising awareness of 211 as the primary number to call. So those are just a few local examples. Also wanted to mention, as I'm sure many people in the audience will be aware of, the upcoming implementation of 988 as a nationwide number to connect with local crisis lines and centers is a really exciting and transformative opportunity, and hopefully will lead to widespread awareness of 988 as the number to call when someone's specifically calling for a crisis situation. Another axis of accessibility relates to whether or not 911 and crisis lines can address different communication barriers, such as for people with hearing and speech disabilities, or for callers whose first language or most comfortable language is not English. So some strategies that we've learned about have included training for call takers and dispatchers as it relates to asking different questions and the right questions and interpreting different ways that people may describe a crisis, especially for people whose first language or most comfortable language is not English. And another key element is the technology infrastructure to support people with different communication barriers and hearing and speech disabilities. So that might include video technology that can support sign language assistance. And another big aspect is texting. So having texting capability for 911, but also texting for 988 and local crisis call centers coming up. And next, a few practices that relate to call criteria and call taking and dispatching practices that can support that decision-making point on diverting calls to a crisis line or a civilian crisis response program when that's the most appropriate response. So in terms of call types and criteria, there are a couple examples of emerging programs that have adopted or are considering not just narrowly defined behavioral crisis call types, but are considering broader criteria and categories for the types of eligible calls that a civilian response team will be dispatched to. So this can increase the likelihood that people in crisis will be connected with civilian crisis responders rather than police. For example, the Community Assistance Life Liaison call team in St. Petersburg, Florida, responds to many mental health related calls, but they also are able to respond to a wider range of call types, such as nuisance complaints, neighborly disputes, and child and juvenile matters. And during the origin of this program, these were call types that police leadership supported diverting to the new civilian crisis response call team, and that program leaders have noted often involve underlying mental health need. One last area I wanted to touch on that's been highlighted by stakeholders relating to call taking and dispatching is assessing the risk for violence and safety. So this is a really tricky and challenging areas. It's a huge responsibility for call takers and dispatchers to make sure that they send the right responders to calls that they're comfortable with and that they can resolve as safely as possible. However, to avoid always sending police by default and sending civilian responders to calls that they're well equipped to respond to and address, some strategies have included reviewing the screening questions and protocols. So seeing if there are ways to avoid bias in how the questions are asked and coded in ways that might overassess the risk of violence. Another strategy can be regularly and intentionally reviewing which calls are dispatched. So if there's a pattern and recurring type of call that does end up still being assessed as a safety risk and being sent to police, but a civilian response team feels they can respond to it, that can be corrected through the protocols and training. And lastly, there may be ongoing training and supports for call takers for behavioral health calls, and that could include having behavioral health experts who are embedded in a 911 call center or sort of do the training to help call takers understand the best type of behavioral health calls that can be safely responded to by civilian response teams.
Thanks, Jason. So as Jason explained, there are many opportunities at the dispatch level to increase the likelihood that people in crisis will be connected with civilian crisis responders rather than police. But experts we spoke with cautioned against the idea that replacing police by itself will eliminate inequities arising from interactions between first responders and people in crisis. Research shows, for example, that Black people are disproportionately subject to coercive mechanisms like involuntary hospitalization, which can exacerbate trauma and sow distrust in the services and supports that are meant to facilitate recovery. So when we think about staffing these new programs, we want to think broadly about delivering culturally responsive interventions, minimizing coercive approaches, and ultimately meeting people where they are. Before I go on, I did want to acknowledge Dr. Amy Watson's work in this area. She's been a real thought leader in considering who, if not police, should respond and what skills they need to address crises effectively, with an emphasis on filling these roles with individuals from communities that are most impacted by over-policing. And this is an area that I know she'll be digging into a bit more as part of another session at this conference. But one area that's stood out in our conversations with experts across the country is the need to recruit responders who reflect the communities they serve. Advocates in particular have described the importance of crisis responders who share lived experience and identities with the people in their communities who are experiencing these crises. To share one example of a program that is focused on racial diversity in recruitment, Rochester, New York's Person in Crisis Team program serves the city of Rochester, which is about 40%, or the population is about 40% Black. And the Person in Crisis Team there has assembled a team that is largely made up of clinicians of color. And the commissioner overseeing this program has said that they also decide to make city residency a prerequisite for employment, underscoring the need for responders who were comfortable navigating the city in a way their suburban counterparts might not be. Another area that we've heard from experts we've connected with is this need to focus on skills and experiences rather than professional designations, and thinking through who exactly should be filling these positions, because we want to avoid unnecessary barriers to employment for people, particularly from communities often underrepresented in the behavioral health workforce, who can provide others with the support they need during a moment of crisis. For example, program leaders from Olympia's Crisis Response Unit, CREW, and St. Petersburg, the St. Petersburg Call program, have said they're not requiring their primary responders have master's level education. And they've described a focus on the nature of the work these responders are actually doing in the fields and the communities they're working with as well, ensuring comfort in serving these populations. An interesting example as in how different communities are thinking through hiring is Toronto. Toronto is a particularly diverse city that's set to launch 4 distinct pilot programs in 2022. And the city will actually contract with different community organizations to operate these pilots. And agencies, the focus will be agencies with a history of serving these different communities across Toronto and delivering, there's this potential to deliver more appropriate, culturally competent interventions because of this approach they're taking. For example, one of the city's 4 programs will be primarily focused on serving the city's Indigenous community. So again, there's this potential to promote Indigenous approaches to mental wellness and crisis response. Additionally, there's opportunity for programs to integrate peers into crisis response approaches, including as first responders. SAMHSA crisis care guidelines have actually identified the incorporation of peers in crisis services and systems as a best practice, but the peer support workforce is often under-resourced with lower salaries, supervision that might not be appropriate given the nature of the work delivered, or given the nature of the work that peers are doing, and limited career mobility and career trajectories for people who choose to stay in the kind of peer work that is separate and independent from more clinical interventions. So what's novel about peer approaches is this ability to identify with people in crisis in a different way that's non-clinical, non-judgmental, and again, meeting people where they are. And in some programs, responders might wear multiple hats in the sense that although they're not formally peer specialists, that's not their title, they still might bring that lived experience to their role. Another example of a program where the peer specialist does play a specific role is San Francisco Street Crisis Response Team. And these are teams of 3 people that are multidisciplinary. They include a behavioral health clinician, a paramedic, and a peer specialist. So you have these different tactics and experiences within the team that are then approaching these crisis situations and delivering the intervention that is most appropriate, ideally, for that person in crisis. So to say a little more about the work they're doing and pivot into training, especially when you have these multidisciplinary teams, there's a need for conducting joint trainings that can foster improved collaboration. So San Francisco's program has highlighted this as really supporting team cohesion. For example, different team members might be used to acting as primary decision makers when they're on a scene. But when they're working together, they would need to collectively tailor their response appropriately to meet the specific needs of that person in crisis. So that might mean empowering a peer specialist to take the lead on a particular call rather than the clinician who might be used to taking charge in some of those situations, because that client is more in need of the support that the peer is providing in that moment than the clinician might be providing, as one potential example. So the joint training idea is one consideration that communities might explore as they're thinking about promoting team cohesion and ultimately equity in their response. And then additionally, ensuring ongoing professional development that looks at eliminating bias and promoting equity in crisis response approaches. Programs have taken this on in a number of ways. St. Petersburg, for example, made delivering implicit bias training a requirement for any contractor leading the call program. Portland Street Response has delivered trainings on working with a number of different populations, including BIPOC communities more generally, immigrant communities, LGBTQ individuals, and other groups in the Portland area. And I do want to shout out the Reach Out Response Network's report on different trainings that programs have offered in this area as a really helpful resource to look at. And finally, I also want to acknowledge the work of Project Let's, which is an organization advocating for and building grassroots responses. And in the trainings they've delivered with providers, they stress the need to really maximize client consent and for providers or first responders to work within their locus of control to do just that. So what is their locus of control granted to them by the law? And what are their opportunities to maximize client consent, basically, so they can avoid those more coercive approaches. Lastly, one other important aspect of equity is ensuring that staff themselves have the support they need to keep doing this work. Pay equity is an important consideration for promoting staff stability, and staff stability has the potential to facilitate greater trust building and collaboration among crisis responders, program clients, and community partners. And you want to retain those skilled and experienced crisis responders who understand the communities they serve and can effectively tailor responses. So communities are thinking about this in different ways. Olympia's Crew and Familiar Faces programs, for example, have actually transitioned from contractors to city staff, which has the potential to offer them greater job security and greater pathways to wage increases and insulation from the city contracting process. At the same time, in some communities, advocates have stressed the importance of greater autonomy from police and government systems. So it's important also to think about opportunities to fund trusted community-based organizations to do this work. So I will stop there and pass it to Jason.
Thanks. So the first two topics, we just covered of how to triage and dispatch calls and how to staff and support programs kind of relate to some of the nuts and bolts of program implementation. To wrap up, we wanted to highlight the importance of ongoing collaboration and oversight. And this kind of relates to some of the introductory materials about why do we prioritize and why do we want to prioritize equity. And it's the goal of addressing the needs of communities who've been most harmed by status quo approaches to date. So it's important to center equity and have collaboration and oversight as a tool for that through all stages of program development, implementation, and evaluation. One great example of stakeholder and community engagement I wanted to highlight is again from Toronto, Canada, and the Reach Out Response Network. So in 2020, they undertook a really comprehensive and inclusive approach to gathering a wide range of input for a crisis response proposal. Their town halls, interviews, focus groups, and surveys included over 100 residents, service users, and service providers. And their aim was really to include input from all different types of groups who are going to be impacted by crisis response services. So this included Black, Indigenous, and other communities of color, individuals experiencing houselessness, LGBTQ individuals, deaf community members, people with developmental disabilities, youth, as well as mental health consumers, peer workers, and a range of other service providers, family members, and advocates. So this is a key part of developing a proposal and then ultimately informing the pilot projects that are set to launch this year that Jackson mentioned. Next, because community engagement and collaboration can often be infrequent or unequal, in the sense that consultations might not be adopted by funders and decision makers. One strategy that has been recommended for establishing emerging crisis response programs is having advisory and oversight boards or some other similar system. It's really important for these oversight mechanisms to be institutionalized and actually have decision-making power, not just be simply advising, but not having power over decision-making. So that might include having access, making sure that there's access to the data to evaluate a program and having some say over the different program elements and I think how a program proceeds. Did want to recommend another speaker at this conference who has put forth some really great recommendations on how to structure those advisory and oversight boards. That's Dr. Talid Al-Sabawi. So in terms of data and evaluation, one sort of baseline and foundational strategy is just tracking race, ethnicity, and other demographic info, along with all the other key measures of access and outcomes for crisis response programs. Many programs have noted that it can be challenging, uniquely challenging, to collect this information in consistent and client-centered ways when clients are in a state of distress or crisis. But a recommendation and strategy is to always ask and to record as much information as possible, but to keep track of when the client is self-reporting that demographic information, and in which cases it's recorded by the program staff. Lastly, I know Street Roots is also presenting another session about their advocacy that led to the launch for Portland Street Response. I just wanted to highlight one other more recent example of how they've been using data to identify potential equity gaps. And this is from Portland Street Response's more recent 6-month evaluation. And something they're doing is doing regular surveys of unhoused community members in the area that the Portland Street Response pilot is running. So with Street Roots and the researchers supporting the evaluation, doing the survey, something that they learned is that people of color and unhoused community members of color in that community were less aware of Portland Street Response, how to access it, and that it's a resource. So identifying this gap has informed plans for intentional community outreach, and I think is just really illustrated of the need to design and also have data and evaluation that considers ways to make sure that these new programs and resources are reaching everyone who needs them.
To wrap things up, as we think about the rare opportunity communities have today to transform crisis response and the demands for systemic change that have made this moment possible, programs must prioritize equity to ensure they are responsive to the needs of those communities that have been disproportionately harmed by status quo approaches. And as a reminder, our report on promoting equity in crisis response programs will be published early this spring, and we're looking forward to sharing more examples of how programs have accounted for equity across planning, implementation, and evaluation, as well as promising practices for implementation that can inform other programs as they take shape. So thank you again to the practitioners, advocates, and other researchers across the country who spoke with us for this report. And thank you all for joining this presentation. We're looking forward to your questions.